Thomas Baldrick here at ASH 2014. Always a pleasure to have with us Dr. V from the MD Anderson Cancer Center in Houston. How are you, sir?
Doing very well. Thank you for having me here.
So you're a busy guy. Let's talk about this exciting phase 3 news that you have with Ruxolitinib.
Yes, indeed. This is very exciting for the patients with Polycythemia Vera. As you know, a few days ago, there was an announcement of approval of Ruxolitinib, a JAK2 inhibitor, as a new therapy for patients with Polycythemia Vera that are refractory or resistant to the first-line therapy with hydroxyurea. This is very important because we do have a standard first-line therapy which is effective. In about perhaps 75% of the patients, there is really good response to Hydrea. And you know, the goal of therapy is to decrease the blood cell count. With that, you eliminate or decrease the risk of blood clotting. That's the goal. But not everybody responds very well to hydroxyurea, and we need something better for these patients. So the response study, that's the name of the study, it's called response study, looked at the patients that did not do well, were intolerant or resistant to hydroxyurea, and needed help. Help meaning they need to decrease the blood cell count, eliminate need for bloodletting, phlebotomy, needing to shrink the enlarged spleen, improve quality of life, decrease white cells and platelets. So all of these were uncontrolled in majority of the patients. These type of patients were enrolled in phase 3 study comparing Ruxolitinib versus best available therapy, meaning anything the doctor wanted to give to the patients. The preliminary results were announced at ASCO and EHA this past summer, and a few days ago there was an announcement from FDA about approval of this medication. What is new since then and what we are presenting here is two important aspects of the study that needs to be known. The first one is what happened with the patients that were randomized initially to best available therapy, and you don't leave the patients on best available therapy if it's not worth pursuing. And indeed, almost all the patients, after initial randomized period, about 32 weeks, crossed over from best available therapy to Ruxolitinib. So everybody was eventually given Ruxolitinib. And now we know that these patients respond to the same extent as those that were initially randomized to Ruxolitinib. This is not unexpected. One would think that the drug works, and it does. The other issue which was very important for me is to analyze patients that by the protocol definition were not judged to be responders. And the protocol definition of responder was complete elimination of the phlebotomy, no bloodletting necessary, normal red blood cell count, no spleen, and this was seen in a good proportion of the patient, but not in all of them. So my question was to the sponsors of the study, what happened with the patients that did not achieve this protocol-defined response? We analyzed those patients, and they are much better than patients in best available therapy. There is this area between protocol-defined response and clinically relevant improvements. So for example, in patients that did not respond by protocol, the average time to next phlebotomy and normalization of the count has been much, much improved than patients in best available therapy arm. In standard practice, you would have another phlebotomy within 2 or 3 months. With Ruxolitinib in these non-responders, the time to phlebotomy was 1 year. Also, their symptomatology markedly improved. So we are learning that it's not black and white picture. Protocol says you did respond, you did not respond. It is the spectrum of a clinical benefit. Some of these did extremely well, and maybe by protocol they are defined as responders, but those that were not possibly by the definitions responders, they do benefit too. So benefit is a whole spectrum, and we need to understand that that is of value for the patients. Similar to myelofibrosis, where we had a goal of shrinking the spleen by 35% by volume. Well, what if you shrink it only by 25%? That's a value too. So it's a whole spectrum. In myelofibrosis, it's a whole spectrum in PV. People are better on the JAK inhibitor.
I can sense your excitement. How significant is this, not only for patients, but for the physicians who treat them?
You know, at the beginning when we started this process of looking for a second-line therapy in PV, there was some skepticism. There are not too many patients, maybe 1 in 10, maybe 15% of PV patients need something else. We can deal with that. Well, look at the numbers. The PV is a relatively benign condition, right? And if you do a little math, what is the incidence, how many people actually live in the United States with this disease, and perhaps it is about 120, 140,000 people living with PV. Hydrea is used in many, and it works in many, but how many are in need of something else? you come up with a number of about 20,000 people maybe. That's not trivial for these 20,000 people that live maybe 10, 15, 20 years, and they're at the risk of blood clotting. So we are now in a position to help them too.
Not trivial for their families either.
Yes.
Very good. Nice work, sir. Thanks for coming by.
Thank you. My pleasure. Thank you.